Good morning, everybody, and welcome to the South East Perinatal Mental Health webinar. We appreciate that people are still joining, but it's 10 o'clock, so I will just kick off with housekeeping. Please can you ensure that your lines are muted and that your videos are turned off until the questions and discussions. And please use the hand raise function if you want to ask any questions. We also make use of the chat box, so please put any queries, questions, any comments from the presentations and that in the chat box, and we'll keep an eye on them as well. And just to remind everybody that the webinar is being recorded in order to make it available to those that aren't able to attend this morning. Just ask, can everybody put themselves on mute, please? We've got quite a bit of background noise. Thank you. Okay. Can I have the next slide, please? So first of all, I wanted to do a very big welcome and also introduce myself to those that may not have met me before. I'm Liz Cullen. I'm Head of Clinical Programmes for Maternity and Perinatal Mental Health for Hampshire Thames Valley, working across the South East during COVID. These are regular webinars that we've run since the first wave of COVID back in March, April last year. But today is the first day that we officially welcome our national colleagues to the webinars. So hopefully we've got people joining us from across the country today, and I just wanted to wish you all a very warm welcome. We hope you will find these useful. I guess I also wanted to just acknowledge where we are today. So it was a sobering milestone yesterday that we reached the 100,000 deaths, and obviously COVID has touched us all, both professionally and personally, and I just wanted to acknowledge that and thank you all for all the hard work that you are doing within your systems, and also for taking the time to be with us today for the webinar, or for those of you that aren't able to join us today but will watch this once the film is uploaded to our website. But thank you. We hope these are useful. We obviously listen to all your feedback and make sure that our subject matter is relevant. So for those colleagues that haven't joined us before, these webinars are a mix of information and advice regarding COVID-19, but also covering a range of other subject areas in line with the long-term plan and the priorities for perinatal mental health. So it's an opportunity really for us to have some shared space to promote best practice across the perinatal mental health pathways, to learn from services both locally but also nationally, and just an opportunity to possibly have some time out within our very busy diaries just to come together and share information. So we hope you find them useful. We always welcome your feedback, and as those of you who are regular attenders will know, we do act on your feedback, so please do give that to us. And if you're not already on the distribution list and wish to be added, then please get in touch with us with the email here on the slide. Okay, next slide please. Can you, Sarah, could you, that's lovely. So this is just a little graphic really to show the themes that run throughout the programme of our webinars on a rolling basis. So we spend time looking at the long-term plan, and there will be webinars focused specifically on that. Also in terms of system-wide collaborative working, and in fact our February webinar is going to be focusing on that. Also health inequalities and marginalised groups, and safeguarding, and those are common themes that run throughout our series of webinars. Lovely. Next slide please. Okay, so we've got another exciting agenda today with some great speakers. Jenny Walsh, who is our South East Perinatal Mental Health Clinical Lead, is going to kick off with just a brief national update. And then we're lucky enough to be joined by Dr. Laura Abbott, who's going to be talking about perinatal women in English prisons and the findings from the research. Then Dr. Shona Minson will be talking about the impacts of maternal imprisonment on children. And then Kirsty Kitchen will finish the session today with pregnancy and early motherhood in the prison environment. We'll have time for questions, hopefully, after each of the speakers, and then if time allows, a bit of discussion at the end. So please do put any questions in the chat box and we will keep an eye on that. OK, without further ado, I will hand over to Jenny.
Good morning, everyone, and welcome to our national colleagues who may not have been on one of these before. I've only got a brief update today. There's a couple of reports that have been published that I think you will be interested in. So the first one, this is a report that the Parent Infant Foundation commissioned ISOS to do on their behalf. Another report looking at services that were running for babies during lockdown and the lessons to learn. I know a number of you on the call were actually attended the all-party parliamentary group when this was first discussed, I believe last week. I'm losing track of time a bit at the moment. I think it was last week. And I would recommend this as pretty essential reading to anybody working within perinatal mental health. There's a couple of things that they mention. One of them is about baby blind spots and how invisible babies became during lockdown in a lot of areas. But also on the positive side, they talk about baby positive services as well. And there's some really good tips in there about, even with lockdown, how services can be inclusive for babies. So I think there's some great reading in there and I'd recommend that one. And then the next one is the Embrace report that was published in December. So the deep dive this time was about epilepsy and in pregnancy. And I think there's something in there for all of us because we're all dealing with women with this diagnosis. And then if I can just have the next slide, just focusing on the bottom half of the infographic. So what they've done this time is looking at the sort of multiple problems that these women that died all shared. And what they've called it is a constellation of biases. And I think this again is really important reading for anybody working in this area. We've got a constant theme running about health inequalities and really trying to make our services inclusive and not having marginalised groups that aren't accessing our services. And I think this particular infographic really picks up on a lot of the things that impact on women's physical and mental health and will be known to you all, but I don't think there's any harm in highlighting how these things combine together to make the situation even more difficult and complex. And while we're on that subject, because of our subject matter today about women in the criminal justice system, I'm sure that our speakers will recognise all of these biases with the women that they work with. So I'm now going to hand over to Laura. So Laura Abbott, Senior Lecturer in Midwifery. And I've had the pleasure of hearing all of today's speakers before, and I have to say you're in for a treat. I think the speakers today are all amazing, and I still am very mindful of what I heard when I heard them previously. So what I would ask of you is, please can you use this time properly for you? And I know these days that we're all multitasking and you're on a webinar, but you're also doing your emails. So can I just say, switch them off and give yourselves the next hour and a half to really listen to these amazing speakers and hear what they're doing with these women. Okay, over to Laura. Thank you.
Okay, hello everybody. I'm just setting up the slideshow to present. Okay. Thank you so much for having me. I'm absolutely delighted to be here today, and I'm going to talk to you today about pregnancy in prison, and I'm going to share with you some of my research. And I've also got two very short films of snippets of transcripts from the women who kindly shared their experiences with me. So hopefully that's going to work for you as well. So I'm going to start with talking about what we already know about women in prison. And we understand, and I'm sure you're all very aware of this as well, that many women in prison have suffered some forms of horrible sexual abuse from their childhoods. They may be victims of domestic violence. They may have drug and alcohol dependencies. And as you're well aware, they may well be suffering from mental illness. And in fact, we believe there may be around 80% of women who are in prison suffering from mental illness. We understand that many women discover that they're pregnant on admission to prison. So all the turmoil and complexities of that. We don't really know how many pregnant women are in prison each year, and that's something that we've been asking for data to be collated upon. We think that there may be approximately around 600 pregnant women in prison each year, but that again, that number is not, we're not sure about that number. And we think around 100 babies are born to women in prison every year as well. And without having accurate numbers, we approximate that around 50% of those babies will be separated from their mothers at or around the time of birth, which adds another complexity with regards to separating mothers and babies. So I know Jenny's kindly mentioned the Embrace report and with their focus on epilepsy, but what was also found in the COVID-19 rapid review was that there were sadly 3 deaths from domestic violence, and there were 2 deaths from mental health related conditions. And these situations were where perinatal mental health was flagged up but not reported. What we also understand is from the Embrace review and report, and also Saving Babies' Lives, that Black and Black British women and women from Black, Asian and minority ethnic groups are also at an increased risk of stillbirth, and they're also at an increased risk of dying in the year of their pregnancy and postnatal period. And we understand that's around 5 times the number for white women. So it's something that is an urgent situation that needs to be looked at. And something else that I wanted to talk to you about was the Prisons and Probation Ombudsman, the PPO report that came from a situation where a woman sadly took her life in one of our prisons in 2015. And I'm going to tell you a little bit about the woman, Michelle Barnes, who was found hanged in her cell on 16th of December 2015. And this was 5 days after giving birth. Michelle had a history of mental health problems, drug misuse, abusive relationships and long-term self-harm. She'd never been in prison before, and when she arrived, she found out she was pregnant. Social services applied for an interim care order when her baby was born, with the intention that the baby would be fostered and then adopted. Michelle had been visiting her baby in hospital and breastfeeding. This stopped suddenly and no breast pump was provided. And this is what the PPO report said. Her postnatal care was uncoordinated and ad hoc. None of the professionals who had previously been involved checked her, and a decision to allow her to visit and feed her baby in hospital was suddenly reversed without proper consideration or explanation. Communication between prison staff and other agencies was poor. To compound matters, Miss Barnes' risk of suicide was not managed well. Staff unaccountably decided to end suicide and self-harm monitoring before the birth, even though Miss Barnes' distress about the imminent removal of her baby had been identified as a trigger for potential suicide. No one identified the postnatal risk, and an opportunity to begin monitoring again was missed at a post-closure review. And I share that with you so that we can really understand the absolute importance of not only us working together, but the importance of really working with women in the separating period after they've had their babies removed, and to recognise that risk of self-harm and suicide for these women. I'm going to talk to you about my research now. So I'm going to tell you what I did. So this was a doctorate piece of research, and I'm a midwifery lecturer, and I didn't have any previous prison experience, so I was going in quite naive. So to cut a long story short, you can imagine that ethics was quite complex, but I was able to enter 3 prisons over a period of 10 months, and I was able to observe the prison environment, and that was around 260 hours. And I was able to interview 28 women in total, and that was 22 women who were currently in prison and 6 women post their release. And to really get a view of everybody, I also interviewed staff, and that really gave me a really very good overview of what was actually going on in the prison system. I'm going to talk to you about what I found. So not surprisingly, really, with how little we already knew about pregnant women in prison, that the system is not designed with pregnant women and new mothers in mind. And this is something that's been coined, a phrase of institutional thoughtlessness, which has been coined by other academics, but it really sort of demonstrates that, you know, pregnant women are really a minority within that system. So the system just is not set up for them. And so, you know, rather than any other sort of words, it's not anyone's particular fault. It's a thoughtlessness of the system. Something else that I found through the interviews was that pregnant women feel intense shame. Now, by the nature of being pregnant, they're going in and out of hospital more regularly than maybe other prisoners might be. They may be with prison officers, they may be handcuffed going to and from antenatal appointments. And whether or not people were staring at the women or not, they felt that gaze of the public, feeling like they were being judged as being a bad mother. And that was something that weighed heavily on each woman that I spoke to. Something else that I found was that women don't receive what they're entitled to. So things like extra food, it was inconsistent. So some women got extra food, some women didn't. Pregnancy mattresses, they often had to be prescribed and took a while to get. Things like breast pads. Now, for women who've been separated from their babies, who are leaking milk, for example, it can be incredibly stressful and really impacts on women's mental health that they're not getting what they're entitled to. Another issue was the risk of harm, both physically and psychologically. And we know from Embrace reports, for example, that having missed medication, it can be really dangerous. And I spoke to women who were on medication for blood pressure or for mental health conditions that had suddenly been stopped as they came into prison. And this caused incredible psychological stress and worry. And really, being pregnant in prison, it's not a safe place from a healthcare perspective. You know, there weren't midwives at night. We know, for examples from the media of some terrible outcomes from women who've given birth in their cells. In my research, I had women that had given birth, a woman that I spoke to that had given birth in her cell, and other women were very, very fearful of this happening, which really caused a lot of distress. And this is just a quote from one of the women that I spoke to, and she said that my mum had a brain hemorrhage through high blood pressure. So that's why I'm worried in here with my high blood pressure. They said they have to wait for confirmation from my doctor. You don't understand, I need it. Now you can really understand how the stress of the woman not having any control or being able to get her medicine was very difficult for her. I'm hoping the volume works on this. This is an actress speaking some of the words, the transcripts of the women that spoke to me.
I think it's because I'm pregnant that I'm more scared. I'm more scared, like, being pregnant, because I don't know how people see or might react to me or might think. And some people, there are some really nasty people in here, there's no doubt about that. So I'm like, yeah, I've got baggy tops so that I can just always hide my bump, and most people couldn't recognise that I'm pregnant, so that's a good thing. Yeah, I'm glad I'm not like out here. Yeah, I want it hidden because I don't know who's who and who's in for what. Most people on remand have obviously figured out that I'm pregnant, but they've been all right with me, actually. I thought everyone's going to be nasty, but they have been all right with me, to be fair. I was so happy when I had my first son. That's why I'm happy to have this baby too. I think most people have children for the fun of it, but I've had children, so I've got a family, so I've got like people too, people that love me, so it's nice. And I think you don't understand how much a parent loves someone until you have a child yourself, and when you have a child yourself, you know that feeling, that protective feeling. So that's why I don't want them to take the baby away. I don't want to lose the bond. I feel I'm strong because I just kept my mum close to my heart, so that's why I feel I'm strong. Probably it would have broken her heart to even think I would be so stupid to do it. But I just think if I'm weak, that's not going to help anything or the situation. So I'll just be strong. I'll never leave my son again. That's why he's going to get me through it, because I know it's just a little vacation. A very bad vacation. It's not about trying to like act strong. It's when you are strong that you just like to not think that you are. And then I know that when I'm at a good place and I can look back, I'll know how strong I've been. I think.
So that was a young woman that I interviewed, and she was 21 when I spoke to her, and she was pregnant with her second baby. She had a 1-year-old child on the outside, and she did not know that she could apply for a mother and baby unit place with her 1-year-old. She was in prison for the first time with a non-violent crime, just to give you a little bit of background. And I've got a few other quotes here for you. This is a woman who spoke to me. She was in prison, she was pregnant, and she was telling me that she didn't have anyone to support her in the birth, and this caused her a lot of stress and distress as well. And she said to me, you can't have a birth companion from like a family member or a friend. You can't even have the officer of your choice. It could be just any random person. And when you think of such an intimate time and not having that support, and we know how important support in labour is, you know, feeling that sort of sense of loss of control was particularly difficult for this woman. This is a quote from a woman who had her medication stopped, and when I spoke to her, and she was on medication for her mental health, and I spoke to her and she said to me, I asked to be padded up because I get stupid thoughts. I get suicide thoughts, but that's what they are, thoughts. I mean, I don't act on them. I can't act on them because I'm pregnant. I won't act on them. You can see from what she said to me, the importance of having that seamless care from community into prison and ensuring that medication does not stop. It's because of the dangers. And this is another actress talking about her pregnancy in prison and impending separation of her baby.
It's funny because I put sweets on my belly and we play games and I like move her, and like her back's round here the minute like that. We play games. I do tell her I love her and that her dad loves her and that I'm sorry. I wrote 2 pages of her saying how sorry I am and everything like that. But social services have probably put that in the bin. I really hope that I'll get a place in the mother and baby unit, but they said no. I've appealed, but haven't heard anything. They're saying it's because they haven't had much chance to work with me. There were 12 people sat in that room, and I pulled my heart out saying I really want another chance, but they said, oh, social services said we shouldn't give you another chance. I just put my head in my jumper and I wouldn't speak to them. I was hoping to breastfeed her, to get that bond with her while we're in it, but obviously she's getting taken away, so there's not much point. I would like to meet the people looking after my child, just say thank you. I'm kind of hoping they don't get too attached because people like to snatch up newborn babies, don't they?
So again, this is a woman. It was quite a common phenomenon in my research with women having their babies removed from them. She was quite young, and this was her first child, and not having that opportunity to become a mother to her baby was incredibly distressing for her. And we know that sometimes that babies are removed for very, very good reasons and essential. However, what the research showed is that the importance of that absolute support for these women who may just disappear and become quite invisible within the prison system, and how dangerous it can be for their mental health. So it was important to hear women's voices and women's stories of their own experiences. Also talking to officers and staff and how difficult and how stressful these situations were for them, and it's important that to understand from their perspective and how we can best support those working within the prison system to support women, because they're working on the ground with them every day. And this is a prison officer who said to me, the officers will go out, escort them, they give birth, and they're the ones that actually see her baby taken away. And then having her to bring her back to the prison, they return and they've got no baby and they're on suicide watch. It's grief, really, isn't it? Dealing with that grief that they've lost their own child. I think that was really poignant from this prison officer's perspective, and to hear how officers are having to hold that grief as well and to deal with women who are going through in such intensity, and how important it is that we support our colleagues that are working in the service. And of course, again, talking to officers and talking to women about their experiences, I think it's really important to reflect on the positive experiences that women have with staff. And here's a few quotes for you that demonstrate this. So one officer said, people think that because we're a guard, we don't care, but how can you not care? An officer talking about her experience of supporting a woman in labour said, you try and blend in the background because you're aware that the midwives are thinking, oh, the prison officers stood there and stuff. So it must be traumatic enough giving birth without the knowledge that someone, well, they might not even know. And here's some quotes from women about their positive experiences from staff. You can choose an officer from here, and I've chosen Miss X because she's lovely. I heard that quite a lot actually from women. She's been to all of my scans, so it's quite nice. So she saw me grow from like literally the first. So it would be nice to have her attend birth, as I'm really relaxed with her. So it would be nice to get her. So it really gives examples of that support and positive experience from staff. It wasn't always that way, but again, it's nice to hear how women appreciate that kindness and compassion, and how important that is just to help a woman through that situation that she's going through. So I don't know how, I haven't been timing myself, so I'm not sure how I'm doing for time, but hopefully we've got some time for questions. So some conclusions really of my research and for today's little presentation. I think the biggest, most important thing that needs to happen is working collaboratively in the postnatal period and throughout the pregnancy, but especially in the postnatal period, as we saw from the experience of the tragedy that happened in 2015. Now, this means, I also think it's important to reflect it in all of our work. And I know, you know, from the work that I'm doing and the amazing work that other academics and organisations that, such as Birth Companions, and also the Royal College of Midwives, all of us working together can make a massive difference. I think we you know, it's kind of a cliche, but stronger together is so important, and that we work thinking of having that woman as the most important person in our care, and just wrap ourselves around that woman, if that makes sense. And we need to also, you know, pay some really special attention and compassion for the women being separated from their babies. They're quite an invisible group. Both physical and psychological attention. For example, as I mentioned before about breast pads, but also the physical changes for women in the postnatal period. If she's got engorged breasts and she's back in the prison and she hasn't got the right fitting bra and she hasn't got pads to soak up the milk and she's visibly uncomfortable and leaking, it creates great distress for her. So it's the little touches, the important things, just making sure that she has her basic needs met physically, but also psychologically. And if we're supporting that woman psychologically, we also need to make sure staff are supported, because it's incredibly distressing. And I speak as somebody who's done research in this area and sought sort of psychotherapeutic supervision for myself all the way through doing this research, how important it is for somebody to be able to debrief and speak about the experiences. Otherwise you end up becoming, you know, become very traumatized yourself when somebody's going through such a difficult thing. And I know this is something that organisations like Birth Companions place a high priority in supporting all their volunteers. So it's really important that we do this as well, and we make time for this. And understanding, and I don't need to say this to you, but mental health conditions can be life-threatening. And just examples of not having medication, not having the appropriate support. And I had experiences with women on waiting lists for counselling and therapy when they really, really needed it. So it's understanding that it can really be life-threatening. Also, it's something, again, thinking about offering the kind of support that allows women to engage. We know that women that are in great distress can often ask for support in the most difficult of ways. They may not be the easiest of women that we work with, but we need to find ways of offering the right kind of support that really encourages women to be able to work with us and to share their experiences with us. And if we're asking questions, we need to know how to respond, and this can be really difficult. And I reflect on my own experiences as well. It's really hard to know how to best respond when we're asking difficult questions, but we can link in with other services. And again, coming straight back to that, working collaboratively and getting support for ourselves as well. And I don't know how I've done for time, but I'm always say I'm incredibly grateful to all the women and staff who shared their experiences with me, and I'm offering any questions, and I'm happy to answer any questions, and if I don't know, I'll go and find out. So thank you. That's the end of my presentation.
Thank you so much, Laura. You've done brilliantly for time as well. So we've got some questions, and I'm just trying to manage the chat box. Let me have a look. So Kirsty has asked, to what extent do you feel women's mental health needs were recognised and responded to by staff in the prisons?
That's a really good question, and I think, again, it was inconsistent. Something that I found with my research was there was a lot of inconsistency. So some women had really good experiences of support and, you know, very responsive staff, but other women you know, had to really ask for again and again. And sadly, it was often women that may have had longer sentences. They may have been seen as more high-risk prisoners because of the crime that they'd committed. And again, coming back to what Jenny, you were saying about embrace and being non-judgmental and not biased, I think that was something that was a really really key, and something that I found that sometimes that there was judgments passed on women, and often those were the women that really needed that extra mental health support. I don't know if that answers the question, but that's what my experience was there.
Thank you. And then we've got one from Julie from East Sussex, who thanks you for your really interesting presentation, and also asks what psychological support or interventions are available in prisons, and was there any training for staff?
Again, I'm not the expert with psychological interventions. I mean, there didn't, one thing that staff did tell me, that there wasn't a lot of training for prison staff or health staff with regards to, especially regards to pregnant women. And there was, again, inconsistencies. For example, there were counselling sessions available, but there was the long waiting list, so that kind of thing. So again, I would say there was inconsistency. Some women and staff did get lots of support, others not so much. And it would be really nice, and I know we're really working collaboratively to try and get some sort of consistency across the board, which would be really good, and model that. And going back to the prison that have done really amazing work is Low Newton, where that was the tragedy of the woman who took her life. They now have a midwife who is their lead for all perinatal women, and they look at mental health from a mental health pathway perspective. So where they have somebody leading that and working collaboratively, it can work very well. So there are some models out there to sort of benchmark care, I would say.
Brilliant. And I've just got a curious question, I guess. Okay. Is one of your women mentioned I asked to be padded up, and it's a bit of prison lingo. I think I might have an idea what that means, but I'm not entirely. Can you just clarify what that is?
More or less to be sort of locked in a, put in a room, and from her perspective, it was almost like in her mind, what I sort of analysed was to have a padded room.
Right,
so to have a room
to keep her safe.
She felt like she wasn't safe. She felt like, and when I met her, she really, I did refer, if anyone's interested, I did refer her like anyone would do in that situation, especially doing research completely out of my remit. But that's what she meant in that perspective. She wanted to be, she didn't feel safe with her mental health. She felt overwhelmed by her feelings, and she she felt very vulnerable, and that's what she meant from that perspective.
Okay,
I think.
Thank you. There's a couple more questions that have popped up, but time-wise, we probably need to move on. Do you mind answering questions in the chat box? Oh, Laura,
of course, I'll have a look. You've gone into a little screen, so I'm going to have a brilliant. Yeah, I will do.
Thank you very much indeed.
Thank you for having me.
I'll
mute myself now.
Thank you so much.
Thank you, Laura. That was a fantastic presentation and very thought-provoking. So, can I have the next slide, please? So we're now going to move on, which is nicely, seamlessly into the impacts of maternal imprisonment on children. And I'd like to welcome Dr. Shona Minson from the Centre for Criminology at the University of Oxford. Over to you, Shona.
Hi, thank you very much for inviting me to do this today. So I've been doing research on this topic for about almost 10 years now. And I have to say, I think it's quite a hard topic emotionally, but I have to say every time I hear Laura speak, I think that pregnancy in prison is harder. Anyway, it's not a a great happy morning, but I think it's really important, and thank you for being willing to listen to these things. Next slide, please. So when children are separated from their parents by the state in England and Wales, it's usually for one of two reasons. So the first is in the family courts, where children have been maybe subject to abuse or neglect. And the Children Act applies, and the best interests of the child are what is called the paramount consideration of the court. So there is statutory protection of those children. And the state appoints it's called a guardian ad litem, who acts for the children in those proceedings. Lawyers are paid for the children, and if they're separated from their parents, they are provided with alternative caregivers, foster carers, who are funded and supported by the state. But in the criminal courts, when a child is separated from their mother because their mother is being sent to prison, it did occur, and it sometimes still does, although it shouldn't, but the child may not even be mentioned in those proceedings. So we've got this differentiated treatment of children. One group seemingly matter and the other group don't. And so I want to talk about what we know about what does happen to children when they are separated from their mums through imprisonment. Next slide, please. So I find it's quite useful to begin by talking about some myths around maternal imprisonment. And I don't know if it's something you've even ever thought much about. I certainly hadn't until I began my research on it. And most people don't give it much thought. So first of all, you would assume that we would know how many children are affected by maternal imprisonment in the same way as we know how many children are in the care population, around 80,000 each year. We would know how many children have a mum in prison. That's not true. No data is collected either at court or in prison. And so the best, schools don't have the information, healthcare providers don't have the information either. And so the best estimates done by some statistical modelling linked to things like child benefit and prison population are that around 17,000 children each year experience maternal imprisonment. We think that's probably an underestimate. So the second myth is that no woman would be sent to prison without a pre-sentence report. Now, I don't know how much you know about court processes or sentencing, but a pre-sentence report is prepared by the probation service at the request of a judge or magistrates, and it gives background information about the person who is being sentenced. And it does have a part on it for home and family circumstances. In my research, I found that many women are being sent to prison without a pre-sentence report. So that stage, which is a really useful information gathering stage, and you would think would flag up things like the fact that children were going to be left on their own, is not actually routine. I'll come to it later. There is now some guidance that says it should be, but a lot of women end up in prison without anyone really having talked to them about it. Thirdly, mothers always have time to make arrangements for their children. This seems pretty basic. Sadly, again, it is a myth. So there are incidents where a woman will go to court for sentence, will perhaps have been told that she's very unlikely to get a custodial sentence. She may, excuse me, she may have had a pre-sentence report which recommends a community penalty, but the judge or magistrate takes a different view, and she is sentenced to immediate imprisonment. On other occasions, the trial perhaps will have finished, she's found guilty, the lawyers have said to her, well, there'll be an adjournment for a pre-sentence report, and the judge decides to sentence on the day. So there are accounts of women being taken down to the cells with the keys to their home in their handbag. They're not allowed to make phone calls. They've got children in school or at nursery, and they're not able to contact anyone. I've heard from head teachers who find at the end of the day that a child isn't collected, and it's only after making a lot of inquiries that they finally discover where the mother has gone. It's really quite horrifying. Fourthly, a pregnant woman will have the same care in prison as in the community. Well, that's Laura's area of expertise and Kirsty's, and so you've heard that things aren't really equivalent in the way that women are treated. Next myth that sentencers sometimes believe is that a mother and baby unit is a great place for a baby. So I did research with judges, and one judge said to me, this was some years ago, and the mother and baby unit is closed, but said, oh, the mother and baby unit at Holloway Prison is one of the best in the world. I never have any qualms about sending a pregnant woman to prison because they'll go there. Now, in fact, at that time, that unit had already closed, so the judge's information wasn't even accurate. But we know that prison is not the best place for mothers and babies for a multiplicity of reasons. And this isn't because necessarily the care in a mother and baby unit isn't good. There are nursery nurses and all the rest, but prison is not the right place for a baby to be. Next slide, please. Number 6, this is a quite commonly held view that if a mother goes to prison, her children are going to be better off without her. We have, whenever anyone's sort of asked or this is put to the test a bit, people tend to have a bit of a belief that if a woman has committed a crime or has been convicted of a crime, then she's probably not a great mother, and it is likely that her children will do better without her. Now, there's been big quantitative studies in the States looking at lots of children with mothers in prison, and I don't think will surprise you to know that a child's attachment to their mother is not affected by her criminality. So for most children, their mother will be, if not it will be one of their primary attachments. Now, many women who go to prison are single parents, so often it is the child's only primary attachment, and that is affected whether or not their mother has shoplifted or used drugs or done anything else. There are, of course, instances where the offending has been against the children, or where for other reasons, perhaps because of a drug or alcohol issue, the children have been living in very difficult circumstances, but that is certainly not the norm, and for most children they are much worse off without their mother. Number 7, if the children are in the care of a relative, they won't suffer any harm, and there'll be local authority support for whoever looks after them. We tend to make that assumption that people will be all right, and judges were very reticent to send women to children if they thought they'd go into the care system. If they thought there was a relative, then they thought they'd be fine. But actually what I found is that often children are going to placements that nobody has checked out. There is no safeguarding in place. Women who go to prison are often quite impoverished, and so their family and friends who might take on the children are in a similar situation. So children tend to be pushed further into poverty, and their education and all sorts of other aspects of their life are interrupted. And there is no local authority support that comes for people looking after a child whose mother is in prison, and there is no automatic support for those children. Number 8, main impact on the child will be they don't live with their mother, but they'll be able to phone and visit her. Well, obviously with COVID, things have changed, and since last March, many children have not seen their mother in prison at all. But even in usual times, it's costly to go to prison visits. They usually happen during the day when the person caring for the children is perhaps at work, and when the children are at school. Financially, it's expensive, it's complicated, phone calls also cost money. So there certainly shouldn't be an assumption that children will be able to maintain contact. Number 9, when the mother is released, the family will reintegrate as it was prior to her imprisonment. Very briefly, many women lose their housing upon imprisonment. And when they come out, they are declared to be intentionally homeless because they have been in prison. They're therefore only eligible for the most basic bed and breakfast or hostel accommodation. If they don't have children with them, they're not a priority to get better housing than that. And without better housing, they can't get their children back. So they're in a really vicious catch-22. And finally, number 10, it'd be wrong for sentencers to take into account the fact the woman is a mother, as that gives some women an unfair advantage. Every sentence looks at the individual characteristics and circumstances of a person. And so this is no different to any other criteria or piece of information about a person that is considered. Next slide, please. So the immediate impacts for children, very briefly, and I set these out, and you may well be able to think of all of these, but when I did research with judges, the only one they seemed to be able to come up with was that children would be physically separated from their mother. But most children will experience a change of home and carers. Less than 10% will remain in their family home, and less than 5% are cared for by a father. So the children, like their mother, also have to move home. They're often separated from their siblings within that change because people can't take on multiple children. As I said, they move into increased poverty and they may well have disrupted education. If the children have had to move to a different area, unlike foster children, who, if I foster a child today, a local school has to give them a place tomorrow. The same does not apply to children whose mother has gone to prison and they've had to move home. And so many children spend months out of education. They experience social isolation of stigma and shame, and very few children tell anybody that their mum is in prison. The changes in the mother-child relationship affect their future stability. The relationship is very much curtailed by the imprisonment, the lack of contact. Mothers often experience quite drastic reduction in their mental health when they go into prison. And as I've said, reintegration is not a straightforward thing. So there was a Dutch study that came out in 2018 that found that if an adult experienced maternal imprisonment as a child, they are more likely than their peers to die before the age of 65. Now that happens if mother or father went into prison, but I think it's times 4 a greater likelihood if it was their mother. So it has lifelong effects on children. There's difficulty in visits, and often children have very changed behaviours because of the extreme grief that they suffer, and this can be internalised. And you see in small children, there's often quite regressive behaviour, bedwetting, sleeplessness, older children, aggression, difficulties at school, nightmares, all kinds of things. And I just say that I've been doing research on what's happening during COVID, and these impacts have been ramped up to an extraordinary level for children who have absolutely no contact and worries about their mothers in prison at the moment. Next slide, please. So serious long-term impacts at the bottom there. There's the study I mentioned about dying before the age of 65. They're also less likely to be in education, training or employment in later life, more likely to have mental health and addiction problems, and are likely to earn less than their counterparts aged 30. Next slide, please. The impacts are also on the people who take on their care. They may lose their employment or have to curtail their employment because they found themselves responsible for children they weren't expecting to have. Their finances take a severe hit because there is no benefit that supports them with these extra children. Housing can become very crowded and very difficult. I think the worst case I came across in my research was 7 people living in a 2-bedroom flat, as that was 2 adults and 5 children. The caregiver's own relationships with perhaps their spouse or partner or other children can be really severely damaged because they take on children who are quite traumatized, and that takes an awful lot of all that they have to give. Their own health suffers, both mental and physical health. So caring for children with a mother in prison comes at very, very high personal cost. Next slide, please. So the positive change there has been in the last year is that, as I said, when I began my research back in around about 2011, there was no obligation on courts to consider child dependence when they were sentencing a primary carer. But in 2019, the Sentencing Council, who produced sentencing guidelines, which all courts are to follow, produced what was called a general guideline of overarching principles. Now, there previously was a line in what's called mitigating factors. So whenever a judge is deciding whether a sentence could be a little bit lighter, they look at factors of mitigation, and these can include things like remorse or seeking help for addiction. And it also included if they are a solo primary carer for dependent relatives. They didn't have to consider that, they just could. And there was no explanation of what that meant. Now, due to there now being some research that I've done and lobbying by various other people and the Joint Committee on Human Rights undertaking an inquiry into this issue, there is a new guideline, and they have set out some of what they call an expanded explanation for sentencers to follow. So this says the court shouldn't impose a sentence of imprisonment where the impact on dependents makes a custodial sentence disproportionate to achieving the aims of sentencing. And the aims of sentencing are not always very clear, but it should be deterrence and rehabilitation, and a couple of other aims. And so what they're saying is if the harms that we're causing through the sentence are too great because of what's going to happen to dependents, then we should be looking at a non-custodial sentence. They need to look at the length of the sentence. So even if you do need to send somebody to prison because of the nature or seriousness of the offending, every day matters to a child. And so it still matters to think about the children, even when it's about sentence length rather than whether it should be custodial. In terms of community sentencing, children's needs and the impact on them should also be considered, because community sentences can actually be very difficult for mothers to comply with if they have children that they're caring for. So, for example, sometimes women will be supposed to attend meetings at a probation office, but they're not allowed to bring children with them. Who are they supposed to leave their children with? Sometimes they're supposed to undertake unpaid work, and that may continue during school holidays, again, leaving them a problem. And because children are so traumatized by mothers going to prison, if a mother has been in prison and then comes out under supervision in the community, where it looks a bit like a community sentence in that they're on licence and they're expected to do various things, if a mother has to choose between upsetting her child, who she's desperately trying to rebuild relationship with, or attending a meeting, she's quite likely to choose to try to look after her child. So these things need to be considered. In terms of pregnancy, I mean, Laura's obviously given a lot on that, but we've now finally got into the guidelines some mention of pregnancy, that the effective sentence of imprisonment on the woman's health and on the unborn child should be considered. And again, Laura has talked and has done research on this, and knowing about the fact that actually many pregnancies in prison are high-risk pregnancies, and that is because the woman is in prison. And so sentencing a pregnant woman to prison does have implications for her unborn child, and also knowing that 1 in 10 babies born to a mother in prison are born in prison or on the way to hospital. It is not a safe situation for them. So there is now a duty on the court that it should have all the information about dependent children before deciding on sentence. It should know whether proper arrangements have been made for the children, and it should adjourn the sentence if those plans are not in place. And it should have all those matters addressed in a pre-sentence report. And so that is the guidance as it stands. It should be acted upon in every sentence. We know it's not yet. There is a long way to go, but that's the structure that has at least been set as being what should be expected. And I think I just want to finish by saying, if you meet women who have been in prison as mothers, the impacts of that period of imprisonment cannot be underestimated for either the woman and her future relationships with her children, or for the children. Thank you very much.
Thank you, Shona, for such a poignant and sobering presentation. We've got time for a couple of questions, so I don't know if people want to raise their hands and ask Shona directly. I know there was a question in the box about the data, and in such a data-driven culture that we live in the NHS, why the data isn't captured about the impact, you know, how many children are affected. Any other questions? Shona.
If I just address that data point, yeah. Liz, that there are various suggestions put up for why the data isn't captured. One is that women are reluctant to give it. I have to say I'm always unconvinced by that, because most women, when they're being sentenced, want the court to know about their children because they want to be able to stay and take care of them. And I think that's been used a little bit to give allowance for not asking the questions. I think some prisons have tried to collect data at times, but there just hasn't been political will to do it, I think, is the main reason. And I think that comes partly because up until very recently, and I think it still exists, there is a real lack of understanding of just how enormous the consequences are for children whose mothers go to prison. and that these are lifelong, and that they are going to cost the state ultimately in all sorts of ways. But there's just not really been an incentive to do the work at this stage.
Okay, thank you, Shona. Any other questions?
I mean, I've got one for our audience, actually. Just wondering if any specialist perinatal mental health services are currently inreaching into prisons in any way. Clearly, this is an untapped area, I suspect, but I was just curious if anybody on the call was doing anything.
Hi, Jen, it's Jo from Hampshire. I'm really sad to say that I don't even know exactly of all the areas in my area which women are imprisoned. So no, I'm not. And I feel quite disappointed in myself that I don't even know where I might be able to provide this, but I'm going to find out. And Heather gave me a really good tip to start finding out that information.
Perhaps we could source a map for a future webinar, just so that you can find out exactly what's in your patch. But I guess, as Shona's been saying, it's very much about, we'll be seeing these women and their children in the community. They're going to be our patients, aren't they, for sure? So kind of an understanding of what they've been through as well is so important.
Kirsty, you've got your hand up, so we'll let you ask your question, and then I'll let Jenny formally introduce you.
Thank you. I hope everyone can hear me okay. I've got headphones in because of two homeschoolers in the house. I just wanted to pick up very quickly before I present on that question about InReach. As we've said in the chat, I think, yes, working with local health and justice commissioners is really important. The challenge is that, you know, there's only 12 women's prisons in the whole country. Women tend to have to travel very far to enter prison, and they tend to be imprisoned very, very far from their area. There's only 6 prisons that have a mother and baby unit. So if you're applying to have your infant with you in prison, you're going to have travelled even further, chances are, than others from where you live. So I think it can be really, really challenging. The other opportunity, though, that is providing more of a chance to connect with women before they are released back to their community. So possibly not even working directly with them in the prison, but being prepared for working with them as soon as they're released, is the NHS Reconnect service, which is looking at making sure that men and women living in prison are sort of connected into their primary and secondary health services before they re-enter the community. And that's got various pilots going on at the moment, including one in Bronzefield prison that serves a lot of the southeast. So well worth having a look at that as well.
Lovely, thank you.
Super.
I'll introduce you now then.
Yeah,
Kirsty.
okay, great, thank you.
So once again, I'm really delighted to introduce Kirsty Kitchen, who, as you can read, Head of Policy and Communications at Birth Companions. And I think you'll all be really fascinated to hear what these guys do. I know I was when I heard this presentation for the first time. So thank you very much, Kirsty, and over to you. Thanks,
Jenny. So morning, everyone. Thanks for inviting me. I will talk a little bit more about the needs and experiences of pregnant women and new mothers in the prison environment. I love and loathe sharing a platform with two very close allies of ours, Shona and Laura, because as Shona said, the power of both of their work really never fails to kind of convince me afresh of the importance of the work that we do at Birth Companions, and the fights that we continue to fight. But they also always steal a lot of my thunder. So I've been frantically rewriting my notes as I've been listening to them, because I don't want to go back over points that they've already very beautifully covered. So next slide, please. A little bit about Birth Companions. We're a small charity. We were founded in 1996. We started out working in a women's prison that many of you will have heard of, HMP Holloway in North London, which doesn't exist anymore. And we were founded out of a furore that developed when Channel 4 documentary discovered that women in Holloway were routinely shackled during labour. And that was a policy that was then publicly supported by the then Minister for Prisons and Justice, Anne Widdecombe. So a group of antenatal teachers started volunteering in HMP Holloway. And so that is where we began. Our work has expanded since then. So we work with women who are in prison. We work more widely with women who are in contact with the criminal justice system and in the community. But we also work with women that have never been in touch with the criminal justice system, but who experience multiple disadvantage of other forms and are living in the community. And I'll talk a little bit more about what some of those factors are as I continue. We support service development in prisons, both those that we work in, and we work in 3 in normal times on a face-to-face basis. Obviously, in the pandemic, we've been working remotely, as everyone has, particularly because prisons have been very strictly locked down. But because of NHS funding, we've been able to expand our support across the whole women's estate during that period. And we've been working with women before, during and after release from prison. We work very hard to shape policy as well as practice in all of the prisons and to improve the care that is provided to women across the maternity system. We also work with a focus on the social services system and the immigration system increasingly, and I'll again touch on that a little bit more. We also publish resources, which I will provide some links to later on in the presentation as well, because there's a couple of things recently published that might be of interest to people. The next slide, please. A lot of this has been touched on, so I won't dwell on it for too long, but there are very good reasons for focusing on pregnancy and motherhood in prison, albeit that we are talking about relatively small numbers in terms of the wider prison population. We know that women in prison tend to access less and later antenatal care, which presents, many issues. And there was a very good report out by the Nuffield Trust about a year ago now that showed that there were a much higher number of missed antenatal appointments and obstetrician appointments from women in prison compared to women in the community. Many reasons for that, including the fact that prisons are massively understaffed and under-resourced and can often fail to provide escorts for women when they need to attend an appointment in the hospital. They receive poorer food, and the food that they do receive has very poor nutritional value in terms of what's necessary in pregnancy. Women have a much higher risk of experiencing premature and or low birth weight babies. They obviously have higher prevalence of adverse childhood experiences, anxiety, toxic stress, and the re-traumatization associated with entry into prison and associated with pregnancy and labour are all very pertinent to this group. Laura and Shona have talked a lot about the separation from infants, and I will mention that a few times again. That is one of the huge issues for the women that we work with. Not only those who are actually separating and are dealing with that separation before, during and after it happens, but also the women who are just petrified that that is a possibility, whether or not it comes to fruition or not. But the anxiety caused by that is not to be underestimated. And as Laura talked about earlier, there is a real reliance on very specialist healthcare and medication, and we know that even sort of baseline medication and healthcare access is poor in prisons. But when you add on the specific and complex physical and mental health care needs of women in pregnancy and the postnatal period, then obviously that's even more significant. A positive note, if there is one to find in all of this, is that we and many other services notice that women are incredibly motivated and engaged at this point in their lives, and pregnancy and early motherhood can be a real catalyst for change. And when services get it right, and when prisons respond appropriately to women at this point, there is a real window of opportunity here, albeit one that is too often overlooked, despite the very best efforts of the women. And engaging with a woman on the basis of her identity as a pregnant woman or a mother at this point is just so incredibly powerful, and something that we emphasise in all of our work. Next slide, please. Tiny bit more about data. I mean, as Shona said, there's many arguments made as to why data is so poorly collected. One of the biggest issues around pregnancy and also pregnancy outcomes, when we've campaigned on the need for better data, not just on how many pregnant women are in prison, but what happens as a result of their pregnancies. Do they experience miscarriage, stillbirth? Do they experience ectopic pregnancy? Do they go on to be separated from their baby, etc.? Do they give birth in prison? All of that data tends to be pushed back on the grounds that this is a small number of women, and that it's very difficult to make sure that confidentiality is preserved when you're dealing with small numbers. I do think we've got some wins on the horizon on that, and there is a commitment in the new pregnancy, birth and motherhood policy framework that is coming out from the Prison and Probation Service shortly, to improve data collection. What's still not clear is how transparent that data collection will be, and how possible it will be for us all to read it and reflect on it, and hold the prison service to account. Other data that's pertinent to this group at the moment, though, L&D is liaison and diversion services. So as many of you will be aware, these are NHS health and justice services that focus on diverting people from prison and working with them on the basis of their health needs. There was a data collection on that, and it appeared that around 4% of 4% of L&D, female L&D users were pregnant or had recently given birth. That's an underestimate, because some regions it was much, much higher, and that tended to reflect much better data collection and much better programme development. But I think that gives a sense of the scale to some degree. PSR's pre-sentence reports, Shona touched on the importance of these. These are the pieces of information that allow a sentencer to make an informed judgment about whether prison is an appropriate option for a woman or not, and pregnancy and dependent children should absolutely be included in them. The number of pre-sentence reports that are provided to sentences has fallen by 52% in the last 10 years, so really the information is not getting through. There has been a steady year-on-year rise in the number of babies born to women in prison. We know that through trawling healthcare records and through FOI requests that have been done by the Nuffield Trust and the Guardian newspaper. And we know that women are very often, too often, recalled to prison for breaching the terms of their licence. When they leave prison, they tend to have a set of conditions that have to meet. And that number's going up as well. It's risen by 6% in the last year, pre-pandemic. Next slide, please. Again, most of this has been touched on, so I won't dwell on it, but there are obvious intersections between multiple disadvantage, pregnancy and early motherhood, and custody. One of the big ones being involvement with children's social services, housing issues, insecure immigration status, and the fact that many foreign national women coming into prison have no recourse to public funds, so they will be released with no benefit support, no discharge grant, no financial package whatsoever. Perinatal mental health is one of the really big ones here. And I think all of that combined, and the many things that are not on that list, just underline the number of professionals that women are in contact with, the number of systems that they are affected by on their journey through prison and back into their communities. And so the importance of multidisciplinary working is just absolutely paramount. Next slide, please. Some recent developments in this area. There has been a lot of movement. That is thanks to the undying efforts of people like Laura, Shona, and our own staff and others. There is a new policy framework coming out shortly. There's been a very long consultation period around that. And this is a new set of mandatory standards and then a very long and currently unwieldy document on operational guidance relating to the care of pregnant women, women who are have recently given birth, whether or not they are on a mother and baby unit, have their baby with them in prison, or if they're separated. It will include women accessing abortion services, experiencing miscarriage, stillbirth, neonatal death, etc. And that is a big win, because previously there was nothing, no mandatory standards whatsoever relating to pregnancy outcomes, the postnatal period. It was only one prison service instruction that covered solely covered mother and baby units. There's the NHS perinatal pathway work, which builds on the excellent work done in Low Newton that Laura talked about. There's the commitments in the long-term plan that emphasised improvements in maternity care and tackling inequalities, there are efforts to translate those into the prison system. They are very limited. The impact of COVID-19, which I will talk about. And in the coming months, there will at some point be 2 prison and probation ombudsman investigation reports into the 2 stillbirths that occurred in the prison system within 9 months of each other in the last 18 months. So 2 babies have died in the prison estate in the last 18 months, which are, shocking tragedies and need to be taken full account of. And there are delays in those reports, but we're hoping they will be with us as soon as possible. All of that movement means that there is an opportunity for some change, and we do feel that there are gains to be made, but they are very small and frustrating. Next slide, please. So the situation in prisons pre-COVID is pretty much as Laura's described. There were already concerns about the level of specialist care, mental and physical health care. There were also concerns about the not just the provision of that care, but the ability for women to access it when they need it, and the fact that we're also reliant in prisons on prison staff providing referrals or escorts to those services can be very difficult. There is a general lack of awareness and understanding across the prison estate, and there are very specific needs around women who are separated from infants. Those women very often become very quickly invisible, because when they return to the prison without their baby, or they enter the prison without their baby, they are on the main wings. They're not in any specialist unit. They're not being sort of specifically supported around those needs necessarily. Sorry, I think someone might not be on mute, so I'm just getting quite a lot of noise in my headphones. So if you wouldn't mind just checking, that'd be great. Next slide, please. Specifically, the mental health needs during COVID, as Shona mentioned, are really significant, and we're only just starting to get the sort of bare bones of that.
Kirsty, you're on mute.
Hello, can you hear me again?
Yeah, thank you.
Okay. Sorry, I'm not sure when I was muted, but just talking about the mental health needs in prisons. So prisons are locked down. generally, at the moment, women are spending at least 23 hours a day in their cells. Sometimes that can be 23.5 hours a day in their cells. The impact of that is massive. Many women haven't seen their children since March last year, haven't had any visits or any contact, apart from maybe a couple of video calls. Video calling is established across the estate now, but the sort of success of video visits in prisons, which is much lauded by the government, consists of a single 30-minute video visit with your family once a month. And doing those with a baby or a toddler is completely impossible, and actually in many cases much more distressing for everyone involved than not doing them at all, which is obviously very distressing in itself. So we've been campaigning to push the government to extend the release schemes that were put in place around COVID to include mothers of children who are under 2 in the community who are deemed to be low risk, because they are unable to maintain their relationships and their attachments with their children at the moment. There is emerging evidence of very high levels of self-harm in women's prisons. There was pre-COVID already lots of concern about the number of women who die as a result of suicide after leaving prison while under probation supervision, and there are anecdotal reports that those numbers are going up very significantly at the moment. Lots of death by suicide reports, and lots of death through possibly accidental drug overdoses or deliberate drug overdoses after leaving prison as well. So that's something that we're staying very close to. Next slide, please. I just will finish off by sharing a story of a woman who we supported recently. I'm going to call her A. We spent several months supporting her. She's a foreign national woman with no recourse to public funds who was released from prison during the pandemic while heavily pregnant. Her offender manager contacted us because she was deeply concerned that A was going to be released with no accommodation and no financial support. She had reported experiences of domestic and sexual violence and trafficking, and we were able to work with lots of other agencies to highlight these vulnerabilities and to try to push the prison and the probation services to make sure that she wasn't released homeless. But that was an incredibly stressful time, lots of uncertainty. Temporary housing was actually secured for her less than 24 hours before she was due to leave prison. So she had no idea where she was going, was deeply distressed in the run up to that. Because she had no recourse to public funds, she was being released with no mobile phone, no money, no practical supplies whatsoever. We worked with many other people to make sure that she was provided with things that she would need in the days after leaving prison. Unfortunately, that temporary accommodation meant that she was actually moved several times within the first few days after leaving prison. She was relocated several times. And at a very key point when we were all incredibly concerned about her mental health, she had expressed suicidal thoughts to several agencies, and she was very heavily pregnant. We were all given the wrong address for her by the Home Office. And there was a period where no one knew where in the country she was. We had no idea of her location whatsoever. We worked with a refugee team at the hostel that she ended up in, managed to get her registered with a GP, which was something that the prison's head of healthcare was meant to have done before she left prison, hadn't happened. And we arranged a mobile phone that she could call us and other services. Probation actually provided her with a mobile phone, but it was set up so it could only accept incoming calls from probation, and that she couldn't use it for any other means. I think her experiences in those days before and immediately after release just go to show that it takes a lot of effort from a lot of people to make sure that women are protected at this point, and that their needs are really not fully considered or addressed by the prison and probation service, despite the very best efforts of some individual officers on both sides of those services. But the systems themselves just don't support women. Next slide, please. I'm going to gloss over this very quickly, but in terms of where we go from here, it's a mix of improving the services that women have in prison, improving those transitions from prison to community. And I think what I talked about before I started presenting in terms of the work being done by NHS Health and Justice Commissioners, the work being done around the perinatal pathways in prisons, the work being done through the Reconnect service and in-reach services to make sure that those transitions are smoother is really important. Ultimately, though, it's about working to divert women from prison, addressing the causes of their offending before that results in them entering prison, and making sure that sentences follow the guidelines that Shona summarised so beautifully, and improving the data. And like I said, I hope we're going to get some wins there. And really important that trauma-informed and trauma-responsive care is just put at the heart of every one of those efforts, because otherwise we end up perpetuating and reigniting cycles of disadvantage that women have already experienced in their lives and carrying those on into their children's lives. The next slide, please. I'll just talk very quickly. There's two resources which I'll post links to in the chat. The birth charter, there was a question about birth charter and improvements since the birth charter, which we published in 2016. The improvements have been small, but I think the new policy framework due from HMPPS is going to be a big win, at least in policy terms. Whether it translates into practice is slightly different. But to complement that, we published a toolkit last year which has pathways mapped out for women who are entering prison pregnant or entering a mother and baby unit, and for women who are separated from their babies, and it includes a lot of focus on their mental health needs as well as their practical and physical health needs. So I'll post a link to that. And then next slide, we've just published a very beautiful book, which is also available as a PDF, called Your Inside Guide to Pregnancy, Birth and Motherhood in Prison. This is written and illustrated for women themselves, before they enter prison and on entry into prison. It covers everything along the way, but it's also very useful for staff who are trying to understand what these women might need, and also lists a lot of the services that they can be connected into directly or indirectly. So I'll post links to those now. And I think on the next slide, it has my email address in case anyone wants to get in touch. Thank you very much.
Wow, thank you so much, Kirsty. I think between the three of you today, you've covered so much and talk about food for thought, but also I'm just astonished at what an untapped group of women this is for a lot of our services, and my brain's spinning thinking about how we can best make sure that they don't fall through the gaps any more than they currently are. And hope that we can make better services for them. We need to do a couple of slides at the end just to sort of finish off, because we've got a slightly different audience today. So could I ask you to answer any questions via the chat? Would that be okay? And then hopefully we'll finish on time.
That's fine, yeah.
Okay, brilliant. I will I'll hand back over to Liz, but I thank you so much. There's so many threads in this work that completely aligns with what we're trying to do with perinatal in terms of trauma-informed, marginalised groups, women with multiple disadvantage. So really interesting to see where we can go with this working together. Thank you. Thank you to all our speakers.
Yes, thank you for the excellent speakers this morning. Really, really thought-provoking. So in the last minute and a half, I've just got two slides quickly. First of all, these are the dates of the webinars throughout the year. The next webinar is on the 24th of February, which is focusing on whole system collaboration with a particular focus on crisis. Of the dates that are on your screen, the 24th of March is highlighted because that now clashes with the implementation date event for the national team for their maternal mental health services. So we will change our webinar accordingly. So you will receive a new date for March. Can I just have the next slide, please? Thank you very much. So just to let you know, you will get a copy of these slides if you were sent the link or the invite directly. If you weren't, if it was forwarded on to you and you want to go onto the distribution list, please email that email address with your details and we will add you so that you receive notifications directly. The slides will be sent out, and also the webinar will then be available on our website for those who weren't able to join today but are on the distribution list. So it just leaves me to say thank you so much for everybody that's joined today. We realise how precious time is at the moment. So thank you for joining. We hope you found it useful. For those of you that were new attendees today, please do feel free to email us and let us know your feedback. And we hope that you'll join us next month. Take care, keep safe, and we look forward to seeing you then. Bye-bye.